Morning, everyone. Pleasure to be back here. And hopefully the weather clears up during the week so that you can see the beautiful lake outside. Um, Thank you, Antoine, for that very kind introduction. Uh, Very kind introduction. And also to Hubert for setting the stage for the course. Valentina, Marianne, and Nick, all for organizing such an amazing course. And of course, the Pansia team, which always does a great job putting this all together. I misunderstood. I thought I had 90 minutes, sorry, 45 minutes, but I'm going to have to compress down because I have to. We're going to try to make sure that between Sylvia and me, we get everything done um, before 1:30, at least, a little after that. So this is just meant to be a broad introduction, to the issue, and I just thought, I'll start from the very beginning, which is Modern Antibiotics, 1929. So if you go visit Tim Walsh, who's going to give you a lecture sometime at the end of the day, he can actually show you the original sort of lab documents from the development of antibiotics at Oxford after the first discovery by Alexander Fleming. Of course, penicillin was very important in saving lives during the Second World War. More people had died because of infectious disease than gunshot wounds in the First World War. And these are pictures of babies with infections who got much better very quickly, just over a period of about 5 or 6 days of being treated with antibiotics. Now, modern antibiotics is only since 1929, since that paper by Alexander Fleming. But there is evidence that there was tetracycline in human bones and in the Sudanese nubia, possibly because this idea of having molds be protective of against bacterial pathogens has been known for a very, very long time to traditional healers around the world, and this is just one example. Now, before the introduction of penicillin, obviously pneumococcal pneumonia was a huge killer. 80% mortality, was known as the captain of death of men. Of course, they only counted men at that time as dying, nobody else. But since the introduction of penicillin, obviously huge reduction in mortality. And there are two people here, one whose face you might recognize here. It's just a bit of trivia. Does everyone recognize the face on the left? No? Okay. That is Alexander Fleming. The other person is someone you've probably never heard of. His name is Giuseppe Brazzo, and so he's the man who's credited with discovering penicillin. And this man, I'll just as an aside tell you, because so many people have been involved in the history of antibiotics, and we tend to sort of compress it into just a few people. Giuseppe Brazzo was the rector of the University of Cagliari in Sardinia. And he was a very important figure. He was very interested in the typhus, and he went out looking for Salmonella typhi in the sewers of his town. And what he was impressed by was that people who were bathing in where the sewage outfall was into the bay never actually got any disease. They didn't get typhoid. So he figured there was one of two things happening. One, either the typhus was being, the typhoid was being diluted by the seawater, or something else was in the water that was protecting against the disease. And so he went out and he cultured it, and he found this thing called Cephalosporium acremonium, which is basically the fungus that he thought was the one that was killing the bacteria, and he tried to get people interested in it. Very difficult. Nobody was interested in it. Then a British medical officer who was stationed there after the Second World War said, "Why don't you write to to the team at Oxford, Howard Florey and his team, to see if they can help you synthesize the stuff." So he wrote this paper, and it was the Journal of Hygiene of the University of Cagliari, and he sent it off. And they got interested, and then we have this drug, cephalosporins. The entire category of cephalosporins grew out of this. Many years later, somebody asked him, "Well, that journal that you published your first paper in, what happened to that journal? Because we've never actually seen it." And he said, "Well, I only created the journal to publish that paper so that somebody would take notice. And after that, there's only one article and one issue of that journal, never seen again." Not suggesting that you do this as a matter of practice, but if you have to make amazing things happen, then you have to stretch a little bit. Now back to Fleming, of course. Not a terribly modest thing to say, but this is what he says, which is didn't really mean to revolutionize all of modern medicine, but heck, that's what I did. But he was also, first to call out the fact that it was possible to make microbes resistant to penicillin in the lab itself by exposing them to concentrations not sufficient to kill them. And this was not just conjecture. By 1940, even 2 years before the first patient had been treated with antibiotics, his team had already figured out how to create resistance to penicillin in the lab. And this was a paper that was published in 1940, well before the first patient was treated with antibiotics in 1942, actually end of 1941 into 42. Now, most of you are microbiologists, so you know what this looks like. The left is where the bacteria is susceptible, so these little discs of antibiotics do their work and then they kill the bacteria. But on the right is resistance, which is really when there's no inhibition. Now, I'll just play this for people who are not familiar with this idea. So let me see.
So what we ended up building was basically a petri dish, except that it's 2 feet by 4 feet. And the way we set it up is that there are 9 bands, and at the base of each of these bands, we put a normal petri dish thick agar with different amounts of antibiotic. On the outside, there's no antibiotic. Just in from that, there's barely more than the E. coli can survive. Inside of that, there's 10 times as much, 100 times, and then finally the middle band has 1,000 times as much antibiotic. And then across the top of it, pour some thin agar that bacteria can move around in. The background is black because there's ink in it, and the bacteria appear as white. First, you see they spread in the area where there's no antibiotic, up until the point they can no longer survive. Then a mutant appears on the right. It's resistant to the antibiotic, it spreads, until it starts to compete with other mutants around it. When these mutants hit the next boundary, they too have to pause and develop new mutations, and much.
Looks like a virus attacked the bacteria. Okay, won't work. Okay, let's move on. Basically, what happens here is that in just about 11 days, the bacteria are resistant to 1,000 times the concentration of antibiotic that would have killed them on day one. 1,000 times the concentration. So it just shows how fast resistance really evolves, because the bacteria are reproducing every 30 minutes, every 40 minutes. They are constantly, through natural selection, figuring out the traits that enable them to survive. Now, this has also been seen over time. Nearly every antibiotic that's been introduced, resistance has developed just a few years soon after the antibiotic was introduced. As, of course, like I said, in penicillin, this was observed even prior to when penicillin was actually introduced. Now, antibiotic resistance is ancient. This is just like we know that the fungi have been fighting bacteria for millions of years, hundreds of millions of years, in fact. And so it is only to be expected that you will find small concentrations of drug resistance amongst bacterial populations anywhere, and even in species that are now extinct. But what has changed over the period from this prehistoric time to now is that proportion of resistant pathogens has grown from perhaps 1 in 100,000 or 1 in a million to 1 in 2, or in some cases 1 in 1. And that is really the process. Now, you might notice that all of these are magazine covers which are talking about superbugs. But you know what's interesting about these magazine covers? They're all from the 90s. This is a long time ago. We've been talking about resistance for a very long time. I think some of us have been talking about resistance for a long time. And if it isn't the cover of Cosmopolitan, some of you may recognize there was an old actor called Brad Pitt, and he was mentioned on a cover. So you can see how truly old that this whole thing is. Now, over time, of course, resistance has gone up. We develop every year this drug resistance index, which is a weighted average of resistance. And you see that different countries have different levels of resistance, and it has been going up over time. And if you look at the most recent numbers on burden, there's about 1.27 million deaths attributable to antibiotic resistance, nearly 5 million that are associated with antimicrobial resistance. Even the number that is directly attributable is almost the same as the number of people dying of HIV, AIDS, and malaria put together. So AMR is not a silent pandemic. It's very much a pandemic. It is just that, we don't always recognize it in the locations where we are, although this is increasingly the case. And in fact, a quarter of all deaths linked to drug-resistant diseases are because of antimicrobial resistance. The burden of resistance is highly concentrated in South Asia and in sub-Saharan Africa, but certainly there's a burden everywhere. But certainly these are places where there's the combination of high levels of resistance, high background levels of infectious diseases, and also poor access to antibiotics. I want to come back to this point again, that poor access to antibiotics actually kills more people than drug resistance itself does. So, these are problems of access. If those same patients had been in Europe, they would not necessarily be dying. Now, we'll talk more about these levels of antibiotic consumption around the world, highly variable around the world. And this is one driver, although not always clear how it drives resistance. Now, the causes of multi-drug resistant infections are varied. These are data from India showing that, Klebsiella is a major risk factor, especially in newborns. But you have everything else going on. You have Pseudomonas, you have E. coli, you have Acinetobacter, some staph in tropical countries. And, all put together, it's, and the absence of diagnostics, which I won't be talking about much, we really have a problem here. Now, the mortality odds, of course, amongst patients with resistant bacterial infections is much higher. That's on the right side when it's extensively drug resistant than even when it's multi-drug resistant. And this is really why we see a global health crisis already underway. Now, if you look at the number of unique beta-lactamase enzymes identified since the introduction of first beta-lactam antibiotics, you can think of this as really the number of ways in which bacteria are able to evade antibiotics. And this has been going up exponentially over time. So, we're basically teaching bacteria how to become resistant. And this is not knowledge that you can take away as long as it's encoded in plasmids and it stays with them. Now, mortality outcomes are much worse in newborns with resistant infections. This was an early study in Tanzania showing that a gram-negative reaction, ESBL positive, MRSA positive, all of these were risk factors for mortality. And you look at the case fatality rates, that's between 30 and 50%, very high rates of case fatality. Even higher rates of case fatality in this study in 3 of the best public hospitals in New Delhi, showing case fatality rates between 60 and 70% for resistant pathogens. But note that it's a high even for sensitive pathogens. Sorry, I don't know if this is working. There we go. So even if you have a pathogen that responds to antibiotics, it's still going to be very high. In a Lancet series that we published about 8 years ago, and we're now updating these for a new Lancet series that will come out next year, the total number of deaths attributable to newborn sepsis that was not treatable with first-line antibiotics was about 214,000 deaths. And this was actually on the cover of the New York Times, which actually summarized it really well, which is about superbugs killing India's babies and really posing an overseas threat. Now, the newborns are one risk factor, one risk category. The other risk category are the elderly population. Now, all of us in this room, all of us, at some point in our lives, will have to go through at least one of these procedures. If we're lucky, just one, possibly more than one of these procedures. And for all of these procedures, we're going to need effective antibiotics for prophylaxis. These are the absolute risk reduction of infection with effective antibiotic prophylaxis in these common procedures, and of course, cancer chemotherapy in the United States. A few years ago, we estimated about 6,000 deaths and about 120,000 infections that were caused by prophylaxis not working as well as it should. In fact, this was unpacked in a subsequent paper, especially for things like colorectal surgery. You have a huge increase in infection probability over time because of resistance, which means that much of what we consider modern medicine, which relies on effective antibiotics, is no longer usable to the extent it used to be, simply because the antibiotics don't really work. And this is the summary, which is the number of additional infections under a 30% decreased efficacy of prophylaxis. Urinary tract infections, these were never fatal before, but now they are in many parts of the world. And this is not just in LMICs, this is also in the United States. This was a long series form done in the New York Times a couple of years ago. Gonorrhea, increasing resistance around the world. This is from the Australian Microbiology Australia a few years ago, and a very clever figure showing that in the 1920s there were no drugs for gonorrhea, and we're pretty much back to that same situation again. Of course, last week we had good news about phase 3 trials of a new drug called zoliflodacin, which seems to work. First drug actually developed exclusively for gonococcal infections. So we may have something there, but 80s would have been a good time to have gonorrhea if there's ever a good time to have gonorrhea, but now is not the time. This is you'll hear more about it with Tim Walsh's talk this afternoon, and the spread of NDM1, New Delhi metallo-beta-lactamase, around the world has really destroyed our ability to use important categories of drugs there. And also MCR1, colistin anyway, was not a great drug to begin with, and now it's not usable because in many parts of the world there's extensive resistance to colistin as well. And many countries report plasmid-mediated colistin resistance in humans, animals, and the environment, or a combination of these. Now, China has now banned the use of colistin in animals, but that's a bit late. The MCR 1, 2, 3, 4, 5 are already all around the world. Maybe there's 6 and 7, which I'm not aware of. So why is this a global issue? Why do we care about this more than we care about, why is the seminar not on, say, on the global threat of, say, the failing arthritis medications? Because there is no such thing. The more you use any of these other medications, it doesn't reduce the effectiveness of someone else. Antibiotics are unique in that when any of us uses antibiotics, we impose what economists call an externality. We affect the ability of other people to be treated with the antibiotics. So in that sense, it's a global public good. It belongs to all of us, and therefore it doesn't matter where in the world you are. What we do has meaning and impact on everybody else. And this is why the United Nations picks up this topic. And we have essentially two options. This is like running out of oil. You can think of antibiotic effectiveness like having oil. You can either make better use of existing antibiotics, or you can find new antibiotics. And both are very difficult to do, by the way. The only challenge is that, in this picture of co-evolution, these are Thompson's gazelles, which run very fast, and cheetahs, which also have evolved to run very fast. If the Thompson's gazelle didn't run fast, it would be lunch, and if the cheetah didn't run faster, it wouldn't get any lunch. Now, in this same scenario, we are not the cheetahs, we are the Thompson's gazelles. And so we're trying to stay ahead of this game. The cheetahs are able to evolve every 30 minutes because of natural selection. And how do we stay ahead? Through R&D and drug discovery, which takes more than 30 minutes. Takes, often 20 years. So this is not a game we can afford to win, which means that everything that you don't do in this course in terms of thinking of stewardship, ways of slowing down resistance, is absolutely essential for the future of public health. I can't emphasize that enough. Now, what are we asking of antibiotics? This is crude infectious disease mortality in the United States over the past century. Went down significantly from about 800 to less than 100. Most of it was because of public health, chlorination, one little blip because of the flu pandemic, but overall, much of it had decreased because of things other than the introduction of penicillin. So public health is really what matters. Now, in South Asia today, crude infectious disease mortality is twice what it was in the United States in 1940 when antibiotics were introduced, when penicillin was introduced. In sub-Saharan Africa, it's 3 times as much. So what we're trying to do is to fight infectious diseases with antibiotics, which is simply not possible. We can only fight infectious diseases with prevention, with vaccines, with infection prevention control, with water and sanitation. The antibiotics can be an accessory to it, but it cannot be the main way. This is like trying to mop your floor when the tap is still running. It's never going to work, and that's what we're really trying to do. And as a result, we use huge amounts of antibiotics. We've documented these over time. As I mentioned, there's huge variation as well. Turkey, Tunisia, Spain all use a lot of antibiotics, and there are other parts of the world that use, very little. There's now a convergence in antibiotic use around the world between high-income, upper-middle, and lower-middle-income countries, and everyone is sort of converging at sort of this point of about 15 DDDs per 1,000 inhabitants per day. But the people who overuse antibiotics are different from the people who underuse antibiotics, and there are a lot of people who underuse antibiotics as well. Now, the global consumption of antibiotics is forecast to triple by 2030. Triple, and this is just in humans. But if we're able to curtail it, and this is what some of the goals are for the UN next year, is to figure out ways in which we don't put greater selection pressure, but we also take care of people who don't have access to antibiotics today, which is very important. India, large population, has a huge antibiotic consumption in humans, but as I'll show you in a second, China consumes far more when it comes to animals as well. Carbapenems should not really be sold over the counter. You can see India, Pakistan, Egypt, huge increases in consumption over time, and this itself is leading to increasing resistance. And carbapenem is also increasing in consumption in Europe as well, potentially because of a perceived threat of increase of resistance. Now, of course, like I said, there are cases where penicillin actually works to deal with pneumococcal pneumonia, 92% susceptibility. And in fact, if we were to even improve access to first-line antibiotics, what we call access antibiotics, we would save a lot of lives just from that, about 400,000 deaths just from improving access to antibiotics today. And non-prescription antibiotic use is common around the world, and the vast majority of antibiotics are not really indicated. They're not needed. A lot of them, for diarrhea, for respiratory diseases where antibiotics are not really indicated at all. Now, the prices are very different across countries, but also for first and second line antibiotics. So if you are poor or you happen to live in a place which doesn't provide antibiotics free of cost, the difference between first and second line antibiotics is not just 2 or 3x, it can be 10 times. And so you're really out of luck if you happen to have a resistant infection in Uganda or India and you don't have the resources to pay for a newer antibiotic. And many people get a drug-resistant infection even though they've never taken antibiotic before. So in Uganda, second-line generic antibiotics can cost 2 to 60 times the price of first-line antibiotics. In China, hospitals derive a lot of revenues from sale of antibiotics, and therefore antibiotics are prescribed. And in India, public health facilities may not have access to antibiotics, and only 58% of people who refer to themselves as doctors in India's cities actually have a medical degree, which means that a lot of antibiotics are just getting overused and misused, and wash services are seriously inadequate. Now, this is what is counted as a doctor in India. For instance, this person has no medical degree. They probably, spent 2 years as an assistant to a doctor. They may have a 10th grade education, and they are able to survive and prescribe because the number of actual doctors and nurses in these populations is very low, even compared to South Africa. Forget about the UK or the United States. In fact, many of the people trained in these countries are in the UK or the United States, which is why they don't have enough doctors. Now, there's a lot of inappropriate prescribing. In fact, the flu season is the biggest driver of antibiotic consumption around the world. You can see January and February in the Northern Hemisphere, June, July, August in the Southern Hemisphere, and influenza in the United States. So I don't want to leave you with the perception that the poor countries do it badly and the US does not. The US is among the highest per capita consumers of antibiotics, a lot of it wholly inappropriate. We are able to predict the flu season just by having antibiotic sales data, which is a terrible idea. We should never be able to predict the flu season using the antibiotic resistance data. Sales data, but we're able to. And in fact, in Europe, this very nice study by Herman Goossens many years ago showed a nice 45-degree correlation between outpatient use of penicillins and penicillin non-susceptible Streptococcus pneumoniae. One end was Netherlands, the other end was France. And we've seen this in other studies as well, that antibiotic use is very closely correlated with resistance, but the seasonality of prescribing affects resistance rates, but not really in viruses. So you're able to see it in bacterial pathogens, but not really in viral pathogens. And you'll hear about this more from Peter Collignon, I'm sure, later on, which is this paper that we did a few years ago, looking at the correlation between antibiotic consumption and resistance. And what we found was this very interesting thing. Sorry, let me try to go back. which is that correlation is not that great when it comes to low and middle income countries. In other words, there are many other factors. Sorry, I missed one slide here. There are many other factors such as governance, like health expenditures, like levels of corruption that seem to predict resistance far more than just consumption does, which means that transmission of resistant pathogens is a bigger issue in these countries than just the selection pressure and generation of resistant pathogens, which is true in high income countries because public health is at a pretty good standard already. And if you look at Access, Watch, and Aware, I'm sure you hear about it from WHO colleagues throughout the week. Access antibiotics are only about a third of antibiotic use in countries like China and Bangladesh. The WHO recommendation is for it to be 60%. We're very far away from that. So we're using a lot of antibiotics that are on watch and reserve, antibiotics that should not be used, right now. Very quickly on vaccines, vaccines can protect individuals from getting sick and decrease infections, can reduce transmission, decrease antibiotic use. All of this can be done. Very complex figure here showing all of that, but a very simple figure is just this. You vaccinate, you have fewer infections, you have less disease and less antibiotic use. Very, very simple. But until 2 years ago, we really didn't have the evidence to really, unpack all of this, but now we do. We have almost 15 studies and now summarized in a WHO report that will be coming out soon, which shows that existing vaccines and newer vaccines can be one of our best interventions for dealing with AMR. So you'll hear about it here, and if you came back for the vaccine courses, you'll hear about it there as well. Diphtheria, for instance, went away, almost entirely after vaccine introduction. We don't use antibiotics for diphtheria anymore. And in fact, if you look at pneumococcal pneumonia, after the introduction of PCV7, both susceptible and resistant disease went down considerably in all age groups, including in the over 65 age group, which was not receiving the vaccine. So the young children, 2 to 4 year olds, were the one receiving the vaccines, but there were benefits for other age groups just because of reduction in transmission as well. And it reduced antibiotic prescriptions and ambulatory care visits as well. And in fact, the prescriptions due to acute ear infections went down nearly half because of the introduction of vaccines. I'm going to just give you just 2 minutes on the agriculture and then turn over to Sylvia. So 2/3 of the tonnage of antibiotics sold worldwide are used in agriculture, and that's because meat consumption has taken off. If people remember what the 21st century was about, it's really going to be about the fact that consumption of animal protein increased at rates that were never seen before. Never seen before. Families that would eat meat once a year now consume it at every meal. And that has consequences when using antibiotics. So the demand for animal protein is increasing at a huge rate. Just demand for poultry in India and China is set to increase 2 to 7%, both because of increase in population and per capita consumption. So this is on the x-axis and the population is on the y-axis. India particularly, starting from a very low base, huge increase. And the productivity per animal is a function of GDP per capita. So there's far more intensive agriculture that's going on. I'm going to skip this next one. But just to say that we have now good data on chickens per square kilometer raised under extensive and intensive systems. And what we find is that antibiotic consumption for food production is increasing rapidly. These are the amounts of veterinary antibacterial agents. This is a bit dated, but very different between countries like Netherlands and Norway. But of course, this is no longer the case, has equalized quite a bit by now. And we're now able to look at global antibiotic consumption in livestock by geography, and you see that China actually is the single largest consumer of antibiotics. In fact, China consumes more antibiotics in animals than all other countries put together. And within China, the pigs in China consume most of the antibiotics. So the one species that's getting all the antibiotics on the planet, pigs in China. Right? And so this is projected to reach about 200,000 tons by 2030. These are estimates from various studies showing antibiotic consumption. This is pigs. These are cattle over here, not as much humans. So humans and pigs, we always knew there was some connection between the two, but we both consume a lot of antibiotics. And then, of course, followed by chickens, cattle, followed by chicken, cattle, and fish. Fish, not a huge amount as far as we can tell. And although this is in the United States, the The distribution of medically important antibiotic drugs used for food producing animals has gone down. It's starting to go back up again, leading to increases in resistance. So we see high levels of resistance, not just in Western countries, but also in carefully done studies in India, for instance, where ESBL rates are close to 100% in broilers, less so in layers. So this is, shows that resistance genes are very abundant in Chinese swine farms. You can find nearly every kind of antibiotic resistance gene, and all being enriched by the fact that antibiotics are going into the soil on a constant basis. I'm actually going to go back to this one, just to summarize this, to say we often worry about resistance in humans because of use in animals. We don't pay much attention to resistance in animals because of use in animals. And this was one study that did that. We basically looked at studies starting from 2000. We see that in chickens and pigs, average resistance has actually gone up threefold in food animals between 2000 and 2018. So even if veterinarians didn't care about resistance in humans, which they should care about resistance in animals, and this is a major reason to worry about antibiotics. So, and meanwhile, consumers are demanding antibiotic-free meat. This is in the United States, where companies that never used to care about antibiotic resistance now say no antibiotics ever, and this is now a consumer movement everywhere. And there have been significant reductions possible. We've seen this in various studies. Changes in performance of pigs fed antibiotics has actually decreased over time, which means you don't need the antibiotics anymore. It's possible to produce animal protein at large scale without the use of antibiotics. We just need to get these methods much more widely adopted. We did this study for the OECD a few years ago, showing that the total cost per pig for taking away the antibiotic growth promoter is just about $1.34. Now, I'm actually going to, so this is the same thing. The potential loss of production is actually very small. It's only about 2.5%. So it's a bit of a myth that we need the antibiotics for animal production. I'm actually going to stop here in the interest of time, and thank you all for your attention.